We've talked about the pathophysiology of lead poisoning, AIP, and PCT, but how do these present? Lead poisoning was covered, but we list here some key situations where you should think about lead poisoning. People who live in old houses with lead paint, or people who work with batteries, ammunition, or radiators can all be exposed to increased lead levels. Acute intermittent porphyria can be remembered by the 5 Ps: painful abdomen, pink or purple red wine-colored urine, polyneuropathy, psychological disturbances, and being precipitated by drugs such as barbiturates. Porphyria is Greek for purple pigment, so its name comes from the disease's characteristic urine pigmentation. To treat AIP, we can capitalize on negative feedback effects of glucose and heme onto ALA synthase and block further progression down the heme synthesis pathway. In other words, we can use glucose to stop heme synthesis and reduce buildup of toxic byproducts, and administer heme so that the patient doesn't become anemic. Finally, porphyria cutanea tarda is the most common porphyria and presents with characteristic blistering cutaneous photosensitivity and tea-colored urine. As I discussed earlier in the lecture, PT tests the function of factors 1, 2, 5, 7, and 10, and an increased PT indicates a problem with the extrinsic pathway. PTT tests the function of all factors except 7 and 13, and an increased PTT indicates a problem with the intrinsic pathway. Hemophilia A is a deficiency of factor 8, and hemophilia B is a deficiency of factor 9. Both of these are involved in the intrinsic pathway, so both types of hemophilia cause an increase in PTT. Other signs and symptoms of hemophilia include hemarthrosis, which is bleeding into the joints, and easy bruising. Vitamin K deficiency is another type of coagulation defect. As was mentioned earlier, vitamin K is required for the synthesis of factors 2, 7, 9, and 10, as well as protein C and protein S. So without vitamin K, you are unable to produce these clotting factors. Since these clotting factors fall into both the intrinsic and extrinsic pathways, PT and PTT both increase. Platelet disorders do not affect PT or PTT, but instead they increase bleeding time. They can also cause microhemorrhage, mucous membrane bleeding, epistaxis, petechiae, and purpura. We mentioned some of the platelet disorders earlier, but let's cover them in more detail. Bernard-Soulier disease is caused by a GP1B deficiency. GP1B is used to bind platelets to collagen, so without it, this adhesion cannot occur, and the platelet plug cannot form. These patients also have giant platelets, as a result, have fewer platelets, so they can be diagnosed with thrombocytopenia. Glanzmann's thrombasthenia is a defect in GP2B3A, and therefore it prevents platelet aggregation, which can be seen on a blood smear. Platelet count is unaffected, but bleeding time is increased. Idiopathic thrombocytopenic purpura, or ITP, is an autoimmune pathology caused by anti-GP2B3A antibodies. This causes destruction of platelets, which lowers platelet count, increases bleeding time, and also increases megakaryocytes, since the bone marrow is trying to replace the platelets. Lastly, thrombotic thrombocytopenic purpura, or TTP, is caused by a deficiency of ADAMTS13. Von Willebrand factor is produced as a multimer, and ADAMTS13 is required to cleave it into functional units. So without ADAMTS13, you develop a von Willebrand factor deficiency. You also see large von Willebrand factor multimers, which cause platelet aggregation and thrombosis, which can in turn cause microangiopathy and red blood cell destruction. Consequently, LDH is increased and schistocytes are present on blood smear. Thromboses can also cause neurologic and renal symptoms, and platelet count is decreased while bleeding time increases. These next diseases are a combination of platelet and coagulation disorders. Von Willebrand disease is the most common inherited bleeding disorder, and is an autosomal dominant deficiency of von Willebrand factor. Since von Willebrand factor carries factor 8, this can cause increased PTT. It also prevents platelet plug formation, since von Willebrand factor is required for platelets to adhere to collagen, so bleeding time is increased. It can be treated with desmopressin, which releases von Willebrand factor which is stored in the endothelium. Disseminated intravascular coagulation, or DIC, is a widespread activation of clotting factors, which not only creates thromboses, but also consumes clotting factors and thus increases PT and PTT. It can be caused by a lot of things, such as sepsis, trauma, obstetric complications, pancreatitis, malignancy, nephritic syndrome, and transfusions. You can remember these by using the mnemonic, "Stop making new thrombi." As we saw in TTP, these thrombi can cause microangiopathy, so you will see schistocytes on a smear. Fibrin split products, such as D-dimers, are produced by fibrin degradation that follows any clotting event, but they are particularly high in DIC, and therefore can be used to diagnose it. The last few bleeding pathologies we'll discuss fall under the category of hereditary hypercoagulability disorders. Factor V Leiden is the most common of these and is a mutation in factor V that prevents it from being degraded by protein C. A mutation in the 3' untranslated region of the prothrombin gene can prevent a sufficient amount of this protein from being produced, and patients with this mutation will often have venous clots. Antithrombin 3 inhibits some of the coagulation factors, so antithrombin 3 deficiency results in increased coagulation. Since heparin works by activating antithrombin, patients with antithrombin deficiency will be less sensitive to heparin and will see a shorter increase in PTT. Last on the list is protein C or S deficiency. This prevents inactivation of factors 5 and 8 and increases the risk of thrombotic skin necroses with hemorrhage following administration of warfarin. Now we're going to begin the oncology part of HEMONC. First, a quick distinction between leukemia and lymphoma. Leukemias are neoplasms of the bone marrow and circulating blood cells. Lymphomas are neoplasms of lymphoid tissue. The difference is the starting point. This slide is a reminder that a leukemoid reaction can look a lot like leukemia. Leukemoid reaction is basically a leukocytosis with left shift that can be caused by acute stresses like infection. Can you think of any infections that cause leukemoid reactions? Some examples are infectious mononucleosis and TB. Check for high alkaline phosphatase because it is usually low in leukemia but high in leukemoid reactions. If you're worried about the possibility of leukemia, the best test is to check cytogenetics or PCR for the leukemia mutations or translocations. Lymphomas can be classified as either Hodgkin's or non-Hodgkin's. Knowing the distinguishing features will help you make the diagnosis. The major features of Hodgkin's include Reed-Sternberg owl-eyed cells, constitutional sick symptoms such as fevers and weight loss, non-tender mediastinal lymphadenopathy, localized nodes that spread contiguously, association with Epstein-Barr virus infection, and old or young demographics. In contrast, non-Hodgkin's does not have Reed-Sternberg cells. It involves multiple peripheral and non-contiguous lymph nodes. It's associated with HIV infection or immunocompromised and has a peak incidence in 20 to 40-year-olds. If you see Reed-Sternberg cells, think Hodgkin's lymphoma. The cells are binucleate, making them look like they have owl eyes. They are often surrounded by a pale halo. On flow cytometry, they are CD30 and CD15 positive B cells. Can you think of other cells that look like they have eyes? One example is Giardia, but hopefully these look different enough they won't get them confused. There are 4 main classifications of Hodgkin's lymphoma: nodular sclerosing, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. This chart is pretty self-explanatory, but I'll highlight some trends. The predominance goes in reverse alphabetical order, so nodular sclerosing is most common, followed by mixed cellularity, and then lymphocyte predominant and lymphocyte depleted. Also notice that they all have high lymphocytes except lymphocyte depleted, and the ratio of lymphocytes to Reed-Sternberg cells is a good predictor of prognosis. Therefore, they all have very good prognosis except mixed cellularity, which has very high predominance of Reed-Sternberg cells, and lymphocyte depleted, which does not have very many lymphocytes. Here's an example of nodular sclerosing Hodgkin's lymphoma. Notice the sclerosis in a few Reed-Sternberg cells, which you can recognize by their pale halos. Nodular sclerosing is the only Hodgkin's lymphoma that affects women more than men. This is a very useful chart that sorts out the different types of non-Hodgkin's lymphoma. It's helpful to differentiate them in your memory as either B or T cell lymphomas. These translocations are high yield, so make sure you take some time to memorize them. Burkitt's lymphoma is generally seen in patients with a history of EBV and occurs in adolescents and young adults. It is caused by a translocation between chromosomes 8 and 14, which moves the c-MYC gene next to a heavy chain Ig gene. On H&E histology, it has a very distinct starry sky appearance. You basically see a ton of dark lymphocytes and paler macrophages floating around. Jaw lesions such as this one can sometimes occur with a form of Burkitt's lymphoma that's endemic to Africa. The most common type of non-Hodgkin's lymphoma is diffuse large B-cell lymphoma. This usually occurs in older adults, but is seen in kids sometimes too. Despite its name, about 20% of the time it may be caused by T cells rather than B cells. CD5 plus mantle cell lymphoma is caused by a translocation between chromosomes 11 and 14. It often occurs in older males and has a poor prognosis. Follicular lymphoma is also particularly difficult to cure. The translocation makes the anti-apoptotic gene BCL2 constitutively active, so these cells cannot undergo apoptosis and thus have unregulated growth. Adult T-cell lymphoma is caused by human T lymphotropic virus and is a particularly aggressive lymphoma. It occurs in about 1 to 5% of patients with HTLV and usually presents about 20 years after exposure. Symptoms include cutaneous lesions. Mycosis fungoides, or Sézary syndrome, used to be thought of as a fungus, but is now recognized as a cutaneous T-cell lymphoma. It occurs in adults and usually presents with cutaneous patches or nodules.